You're in for a real treat today. You're going to hear from 4 internationally recognized experts who are going to talk to us about a topic that affects all of us, and that's how cancer affects women. First in this all-star lineup is dermatologist Dr. Stephanie Savory. I have to tell you, give you a full disclosure, that Dr. Savory is my dermatologist. But I encourage you not to judge her clinical skills based upon me, because she had so little to start with. She has done an amazing job of just getting me to where I am, so please take that in mind. Dr. Savory practices in general and cosmetic dermatology, and she specializes in pigmented lesions. Those are the ones you're going to see up on the slides here today that might be melanoma, and you're going to find out about melanoma today. And she focuses on patients with a personal or family history of melanoma and or numerous clinically atypical or dysplastic moles. As part of her focus on pigmented lesions, she offers full body photography, which is similar to mole mapping, but not the moles that are in the ground, right? Okay, these are the ones that are on your skin, right? Okay, good. All right, and she is president of the Dallas Dermatologic Society and a member of the Dallas County Medical Society, Texas Medical Association, American Medical Association, and the American Academy of Dermatology. Please join me in welcoming Dr. Stephanie Savory.
Thank you so much for having me, Keith. Thank you so much for the invitation. Thank you also for allowing me to come and speak to you. I am very passionate about this subject. Pigmented lesions and melanoma is my specialty niche within dermatology. I am in the dermatology department. I'm the director of the Pigmented Lesions and Melanoma Clinic at UT Southwestern. Can you all hear me well? So we're going to go through these topics today. I'm just going to start with a few overview and facts, but before that, I want to bring attention to the subject of skin cancer and melanoma. Skin cancer is not just skin deep. It's not a superficial annoyance or a minor blight on beauty. This is Ronald Reagan in 1987, shortly after he was diagnosed with the basal cell on the tip of his nose, and he's saying, I've told everyone to think of my nose as a billboard warning people to stay out of the sun. Celebrities have also gotten in on the public service advertisement and warning about skin cancers. This is Hugh Jackman after his 6th basal cell, and he's saying, another basal cell, thanks to frequent checks and amazing doctors, all's well, looks worse with the dressing on and off, wear sunscreen. So fortunately, we have strong voices out there that are spreading the word about skin cancer. When we're talking about skin cancer, we're most often referring to one of these 3 entities: squamous cell, basal cell, and melanoma. Together, squamous cell and basal cell are referred to as the non-melanoma skin cancers, and melanoma is in a class of its own. Skin cancer, unfortunately, is a highly prevalent disease in our society. 1 in 5 Americans will actually be diagnosed with skin cancer by the age of 70. And this is one of my favorite graphics. This is a composite of non-melanoma skin cancer cases thus far in 2019. So estimate 5.4 million. And number of non-melanoma skin cancer cases, as you can see, vastly outweighs all other cancer cases combined. This is a little bit difficult to estimate because squamous cell and basal cells don't require reporting to registries and agencies. However, basal cell is the most common skin cancer. Non-melanoma skin cancers together are the most common form of cancer in the U.S. So hugely prevalent. We're just going to review a little bit of the clinical presentation of melanoma in specific. So we often refer to the acronym ABCDE. You may have heard of this, and it helps us to remember some of the features that we're looking for in melanoma. So just going through them, A stands for asymmetry. This is a mole that if you folded it in half, one side wouldn't match the other. So for example, we folded this mole on itself in half. Obviously, this huge nodule doesn't match anything that's below. This is an asymmetric lesion. Border irregularity, so we have these scalloped borders, not nice and smooth or even, very irregular. Color, we'll often see variation in color, so this particular lesion features dark black, browns, pinks, some of them can even have whites. Diameter is not my favorite because I've definitely seen melanomas that are smaller than the eraser on the pencil, which is what diameter refers to, but it fits the D nicely. And then one of my favorites is evolution. So this means that you look at a suspicious mole at 1 month, and then a couple of months later, you see that it has dramatically changed. So malignant things change, melanomas change, lesions that aren't behaving as they should evolve. Another one of my favorite sort of monikers for identifying melanoma is called the ugly duckling. So this relies on the concept that everybody makes a signature mole. So everybody has a mole that is what their body makes, and that's what their moles look like. If you're looking at somebody and you see their moles, they all look alike, but one stands out, it may not follow all the A, B, C, D, E's, but there's something about it that's a little bit off. We call that the ugly duckling. So we often go for the ugly ducklings because they're the outlier. It doesn't match the rest of the quote-unquote family. You have to also remember melanomas can appear in very odd places. We don't know why, but they can appear where the sun doesn't shine. So genital areas, between the toes, bottom of the feet. They can be pink. They don't always have to be black. And oddly enough, they can appear under the thumbnails, under fingernails, toenails. This is a melanoma in situ that is a very subtle melanoma in situ, but this is a patient who has no other lesions like this on any of her other finger toenails. And we see just this solitary stripe of color. This was a melanoma in situ located right down there. Did very, very well with appropriate surgical management. So now the most important part for our talk this morning, detection. Detection, screening, and prevention in future research. There are two factors that go into how somebody acquires melanoma, genetic factors and environmental factors. So when we're talking about genetic factors, we look at things like their phenotype, what kind of skin and hair do they have, how easily do they burn and freckle, do they have a family history, a personal history of melanoma. Importantly, your personal history of melanoma confers a much increased risk for developing a second and even a third melanoma. So personal history is very important. And also the number of moles that person has. We also have the environmental, what we refer to as modifiable factors as well. So history of UV exposure, and this is lifetime cumulative UV exposure, dating back to when you were a young kid on the beach getting sunburns. And this includes any history of indoor tanning, whether you preferentially have gotten intermittent versus cumulative sun, so whether you're mostly an office worker who goes and does intense sun during beach vacations versus you're outside chronically. All of this is important in identifying a patient at high risk for melanoma. And then immunosuppression, lastly, makes melanoma and other skin cancers a little bit more prevalent. So we focus on what we can change, and that's oftentimes the environmental factors. Starting to identify melanoma begins with a good visual exam. The dermatologist or many internists, primary care providers will often give excellent thorough skin cancer screening exams. But we'll often go through areas that you may not have thought of before. Scalp, behind the ears, within the folds of the ears, between the toes, soles of the feet, the genital area, between the buttocks, underneath the arms and the armpits. So we go through every inch. We also look in the oral mucosa. We try to pull down the eyelids, just looking for any place where there could be pigment hiding, pigment that's not supposed to be there that could be a melanoma. If we do find a suspicious lesion, then we have an instrument called a dermatoscope that's very high magnification, and we can use it to see some of the features of the lesion, if they're irregular, regular, if they have melanoma-specific features, or others that might be concerning. But what do we do when we have a patient like this? So this is what most of my patients look like. They come to me, they don't just have a few small isolated moles that are easy to screen for. You take any one of these and they're large. Some of them have variable colors to them, irregular borders. Any one of these could be a melanoma, and obviously this patient's already had multiple excisions. So what do we do with a patient like this who probably has a lot of clinically atypical moles, but which one's the melanoma, or is there melanoma here? So we, in my clinic, do full body photography. At this time, there are only 2 academic centers in Texas that do full body photography. My clinic at Southwestern and MD Anderson. And what we do is we put our patients into standardized poses. We then crop those photos so we get a baseline series of shots. And then for the next 10 years, we use those baseline photos at every subsequent follow-up visit, and we are looking for change. So as we said before, E, evolving, malignant things change, benign things stay the same. So we can look at a mole that maybe the patient has had for the entirety of the time we had their photographs. We look at that, there are no changes, that stays the same. But maybe this mole is suddenly growing and its borders are starting to change. That's the one we identify. And literature supports the use of full body photography. The literature over the years has shown that full body photography captures melanomas when they're at a thinner stage and results in fewer biopsies. Our patients are definitely a fan because they're not getting 4, 5, and 6 biopsies every time they come in for their skin checks. Full body photography is best used in conjunction with dermoscopy, so high magnification photos of the individual lesions in question. It's important to remember, though, that full body photography allows you to also monitor the background normal skin. So every mole has about a 12 to 20% chance of turning into a melanoma, and that figure is hard to arrive at, but that seems to be the range that most literature suggests. However, the vast majority of melanomas therefore arise on completely normal skin. So in addition to being able to monitor the suspicious lesions that are already there, full body photographs are useful for monitoring background normal skin that could present with a melanoma down the road. This is a case where I had a patient who had full body photographs at his baseline, and we see this suspicious lesion. I didn't really think much of it at the time, but at his 6-month visit, we see there's the white patch, and there's the white patch. Here's the neighboring mole, looks the same. But now this small little brown segment has grown. This is just 6 months of change. So we biopsied this lesion, and it turned out to be a 0.2 millimeter melanoma. This is very subtle. I don't know if without the photographs I would have necessarily picked up on this. So computers are becoming more prevalent in our society, and we can teach computers to screen and thereby kind of cut down cut into our efficiency. So newer systems now are putting the cameras on a stand that within seconds can scan a full body and give you an overread that, if done with each subsequent visit, you can actually overlay the photographs, and the computer algorithm will identify for you lesions that might be new, for example, or changing, or irregular. So you can specifically look at those during your visit in addition to doing the rest of your full body. So we always want to know what's upcoming, what's in the future. We already have a lot of artificial intelligence around us: Pandora, Netflix, voice recognition with Siri, facial recognition in Facebook. So this technology is there to be harnessed. In 2017, a team at Stanford University showed us that we could potentially use this technology for melanoma screening when they trained a computer algorithm to detect melanoma at least as well as 21 board-certified dermatologists. So we've got some advancement. This can be done. Obviously, huge potential for this technology. Ideally, you could even put it into a smartphone app that would allow melanoma screening and detection to thereby be publicly available. But we have to remember that much like research, the quality of what you put in is the quality of what you come out. I also like to think of it as the quality of training your computer is equal to the quality of decision making that you are going to get out. So we're still fine-tuning just the images that are used to train computers to do this. So we're getting there. Just going to go through what causes skin cancer. I think we all have heard that UV radiation is a huge cause and a huge contributor to skin cancer risk. The vast majority of melanomas are due to natural or artificial UV light. Even one blistering sunburn doubles the risk of developing melanoma later in life. But good news is that daily sunscreen use, and this is just on the low end, SPF 15 or greater, reduces that risk of developing melanoma by half. So there is hope out there. At this point, we can say that more people have developed skin cancers from indoor tanning than lung cancer from cigarettes. So very, very sobering. And this is a case in point. So this is from the New England Journal. This was a wonderful image that was published several years ago. This man was a truck driver for 28 years. And yep, guess what side the sun was on. So this is called dermatoheliosis. This is effect of UV damage. So on one side, we see this, the effect of normal, natural, inherent aging. You have a little bit of volume loss, a little bit of some sagging, a loss of elasticity. But on the other side, we have this leathery skin, exaggerated creases, nodular colloid, and nodular elastosis. So collectively, this is known as dermatoheliosis. Glass blocks UVB, but it lets UVA through readily. So when you're driving, especially if you have a long commute, think about that. Sunscreen just every day is very useful for those times that you're in the car. Helps to prevent dermatoheliosis. Now, lastly, we're going to wrap up with prevention and future research. So, alluding to UV damage, sun protection is of paramount importance in preventing skin cancer. Sunscreens, broad spectrum, water resistant. We used to say 30 to 50, but now we say higher the better, just the highest you can get. And that's because we're not all in laboratory testing conditions. There's a specific thickness you have to apply at your sunscreen so it will achieve the SPF on the bottle. And not all of us are as good at achieving that thickness. So for that reason, higher the SPF you can get, the better. And there's been a lot of talk about the chemical sunscreens. Mineral sunscreens are generally recognized as safe and effective by the FDA. So if you are in any doubt about the coral reefs or chemical sunscreens in your bloodstream or sensitivity, etc., mineral sunscreens have a little bit more of a white tint, but they are very safe. Sun protective clothing, so not all fabrics are created equal. Polyester fabrics have a tighter weave than cotton and linen. They let less UV light through. But also UPF infused clothing will go a huge way. Long sleeve, long pants, broad brimmed hats, not baseball caps. And then of course sun avoidance. So I like to say if your shadow is shorter than you are, stay inside. If your shadow is longer than you are, then the sun is relatively less intense. It's safer to be outside with your good sun protection. So that's one way to think about it. Some states are also getting in on restrictions, tanning restrictions for minors. We need to do better though, and unfortunately it is pretty easy still for teens to get around these tanning restrictions, as numerous journal articles have shown. So we've got a little ways to go, but we're on the right track. Lastly, future research. So I'm actually really proud to present these next two slides because my research team has worked in close collaboration with Moncrief over the past couple of years to achieve these results, and our work would not have been possible without Moncrief, so we're very grateful. So the big problem is there are not enough dermatologists to do all the population screening. We can't do everything. So we're trying to look at healthcare extenders and other healthcare providers to help us. One of these ideas we had is to use nurses, oncology-trained nurses who are already doing routine cancer screening. And we used oncology nurses here at Moncrief who are already routinely doing breast and cervical cancer screening. We tried to train them to do full-body screening skin exams simultaneously. We divided our training into two phases, a lecture-based training and then a clinical full-body skin checks with live patients training. And what we found is very interesting. We found that nurses were very able to learn and identify suspicious lesions when presented in lecture format, but that was a lot harder when it was a real-life situation. All of a sudden, there was background noise. There were benign and malignant lesions potentially mixed in. So we have realized that we are learning in isolation. We present suspicious lesion, but we don't present suspicious lesion with background noise as it is in real life. So that's kind of brought a big question up for us. How do we learn? How do we optimally teach people to screen for skin cancer? And this has never been done before. It's never been really looked at, the concept of teaching skin cancer screening. So we were very excited about that. Also on this subject of not enough people to screen, there are certain areas that, of course, are at lower density for dermatologists and primary care providers than others. One of those areas is rural parts of the country. So we were trying to address the lack of dermatologists and the lack of screeners in rural areas by trying to investigate barriers to care. We used West Texas as a representative model. Why are primary care providers in West Texas, what are some barriers to care? Is it exclusively time? Is it other commitments? And we got some interesting results from an on-the-ground survey that we did. Basically, lack of time and privacy concerns were big, but insufficient knowledge and education was also cited, particularly when it comes to patients with skin of color. So not your typical Caucasian skin tone, but more of the Hispanic, African-American skin tones, and how melanoma presents in them. So for the future, we're actually working to develop online curriculum, educational tools that with their input, so this is more streamlined, efficient, provides more knowledge that is fast, bite-sized, easy to obtain, and thereby help to educate and bring more screeners on in these rural areas. So just to sum up and encapsulate what we went over this morning, onwards we go. Our goal ultimately is to develop more screeners, to have more people on the ground helping us to detect melanoma in the future, because we can't do it all on our own. So whether that is artificial intelligence and computer systems, and we can adequately train a computer to do this for us, that would be wonderful. But we would also love to expand into other healthcare providers. Nurses, the nursing pool has not been adequately explored, but that's definitely a resource for us. And then also helping primary providers who maybe don't have the time and the luxury of certain resources that city-based providers do, helping them optimally to work skin cancer screening into their normal day-to-day as well. Thank you very much.
Thank you, and Laura.
Could you address two understandings that I've been told about, and that is that previously diagnosed cancer patients, survivors, have a higher risk of melanoma.
Yeah.
And then also, could you address the young adult population and the rise of melanoma?
Yeah, so two excellent questions. One, the concept of increased melanoma specific in patients who previously had cancer. So there's so much that goes into cancer treatments. There's radiation in particular. There can be immunosuppression. So we know that patients who are immunosuppressed, whether by chemotherapy, stem cell transplants, have a 4 times higher risk of developing melanoma. So that is definitely something of concern. And at Southwestern, there is a young adult cancer care program where children who had cancer are followed into their adult years. And part of that program involves skin cancer screenings. Just patients who have had radiation alone have increased risk for basal cells, so we always screen for that. But if they also have had a stem cell transplant, then they are lifelong at higher risk for skin cancer, melanoma, but very much so squamous cell and basal cell, so that is very true. And your second question, sorry, are you?
Just the young adult population in general, how it's growing in melanoma cases.
Right. So young adults, unfortunately, have had so much exposure to indoor tanning, and not only that, before the message was really adequately expressed about the dangers of skin cancer and sun exposure. So I think this reflects really well on what I'm seeing in my clinic too. I have kind of two populations I see. The older adults who lived through the baby oil and iodine times, and then also the younger adults who lived through the times when the 90s, when indoor tanning was what you had to do before vacation, before your homecoming, before prom. And we know that even just a few exposures of indoor tanning in a genetically susceptible individual can start a melanoma process. So I'm definitely, I think what we're seeing now in terms of population for melanoma is reflected in what I'm seeing in my clinic.
I'll get to you in just a second. Great question. Talk about non-cancerous organ transplant recipients and their increased risk for melanoma.
So organ transplant recipients, solid organ transplant recipients.
So kidney transplants, lung transplants, hearts.
Yeah, heart, lung have the greatest immunosuppression. So we see they have 65 to 250 times higher risk for squamous cell, which is enormous, but they also have 4 to 8 times higher risk for melanoma as well, and that's largely from the immunosuppression. So our immune system just naturally scavenges for precancerous cells, and it helps to destroy those precancerous cells just on a daily basis. And this is precancerous cells from UV exposure, just errors and mutation. But without that luxury of an intact immune system, patients who are immunosuppressed, solid organ transplant patients, particularly heart and lung, because they are so significantly immunosuppressed compared to kidney and liver. They do have a much higher risk for developing melanoma, so we watch them very closely in a special high-risk skin cancer organ transplant clinic.
Going back to the young adults, now spray tans are more popular than sitting in a machine. Is there any evidence about what that does, if anything?
Well, the one thing, we don't know quite what happens when those particles are inhaled, so really advise, just almost like the spray sunscreens, try to avoid inhaling the particles. But many of the pigments in the spray tans is actually just derived from a vegetable base, so it's safe, especially compared to the alternative, which is indoor tanning or outdoor tanning.
And then along those lines, when you said you referred to the spray the spray sunscreen, oxybenzone, I heard causes cancer, and that is high in most of the spray sunscreens. So, do we use the spray or not use the spray or whatever?
So oxybenzone falls into the category of the chemical sunscreens. There are two types of sunscreen. There's mineral and chemical. Mineral is zinc and titanium oxide. These mineral sunscreens work by reflecting the UV light. Chemical sunscreens include the long names avobenzene, oxybenzone, etc. And those are molecules that when UV light hits them, they change. So they absorb the energy from the UV light so that when it hits your cells, it's not as damaging. Those are ones that we're still learning more about. So there was a big splash in the media a few months ago when the chemical sunscreens were found to be detectable in the bloodstream after consistent use. Nothing's been proven yet, which I think is why the chapter has been opened, and we're now looking more into the chemical sunscreens. However, the mineral sunscreens are proven to be much safer. Also, oxybenzone is bad for the coral reefs.
Well, and it's been banned in Europe, hasn't it? Or is that, I
Yeah.
think it's been banned in Europe.
There's several that they have that we don't have, and but it hasn't been definitively been linked to cancer.
Okay.
But there are still kind of gaps in knowledge with the chemical sunscreens.
Does
And
it
then
say
the last-
mineral on the sunscreen?
It doesn't.
Oxybenzone, it says it, it's
Okay.
an ingredient.
Yeah,
You've got to
many
look.
times the mineral sunscreens will go under physical. So like physical blocker, we'll say mineral. Not the same thing as natural. Natural sunscreens often have plant-based kind of byproducts, and they're not as effective.
But if you look like, more expensive spray sunscreens have more of that particular ingredient than the cheaper ones. Like the Walgreens generic brand has 3% and Neutrogena has 6%.
But if you have any questions, zinc and titanium are our old standbys. Those are safe. And plus, we don't really love the spray sunscreens anyway because they're convenient, but we don't know, A, what happens when they're inhaled, and also they don't provide a nice thick layer. Creams and lotions are great, at least for a first application. Sticks are good too, because in addition to the SPF, you're getting a little bit of a thickness, a physical layer. So any questions, zinc and titanium are the old standbys.
You got a question over here?
I just wanted you to talk a little bit about if cancer or skin cancer goes undetected. My husband has had a mole for a long time that I keep asking him to get checked out.
Yeah.
And you said so many people have it. How quickly does it metastasize or spread?
Yeah, so that's a great question. It's one that's a little bit difficult because it goes case by case and variant by variant. Most melanomas are superficial spreading, so that means that they just kind of spread along the surface of the skin like an oil slick. They don't dive, they just kind of spread out, and after a period of what could be months or years, then they start to become invasive, and that's where the danger for metastasis occurs. However, there is a variant of melanoma called nodular melanoma. That is what we particularly as dermatologists are very worried about. And instead of spreading across the surface of the skin like an oil slick, it preferentially dives down. And anytime a melanoma begins to invade down into the skin, the deeper you go, the higher the risk for potential metastasis. So that's why we always recommend at least everyone get a baseline skin check. Your dermatologist or primary care provider would then tell you if you're high risk, if you need to come back more often, and also the opportunity for biopsies. So we definitely get that looked at.
He needs to go see the doctor.
Yes. That one needs to be looked at.
We got time for one more, yes.
Is there a certain, a particular organ that it would metastasize to, or is it?
Yeah, so it's not really an organ system, but the very first place melanoma from the skin will often go is to a draining lymph node basin. So this is why when patients have melanoma, then depending on the depth, in addition to doing the surgical excision to remove the melanoma, the sentinel lymph node or the draining lymph node will also get tested to see if there are micro or macro metastases of melanoma there. After that, melanoma likes to go to the brain, it goes to the liver and the lung. So we often will do a PET scan, particularly if the lymph node basin is positive. We'll often do a PET scan just to see if any other organ systems are involved.
Thank you.